Hello everybody, Peter Cass here. The new resuscitation guidelines are out. The 2010 resuscitation guidelines are out from the Australian Resuscitation Council. It's important just to go through them very, very quickly. Now there's a few things to talk about. The relevant points are the 30:2 ratio remains. The importance of defibrillation as ever is emphasised. The importance of good cardiac compression and minimal interruption of cardiac compression, aiming for a 30:2 ratio, and even when we're giving those two breaths, to do them very, very quickly. The emphasis again on commencing CPR or cardiac compressions right after defibrillation is very important. The distinct things that occur in the Australian Resuscitation Guidelines and Advanced Life Support now are that, so we do 30:2, we give a first shock, we give a second shock, and after the second shock we give the vasopressors, and then after the third shock we give the antiarrhythmics. And so the approach to a resuscitation would be that you basically look for a defibrillatable rhythm, because defibrillation still is the only thing that's shown to make a difference. CPR as such, or cardiac compression, should be done on the lower part of the sternum, compressing the sternum to about 5 centimetres. We're looking at about 100 compressions a minute. Doing more than that or greater than 120 compressions a minute has not been shown to be very, very effective. We're talking about adult patients at this point. Certainly CPR gives you up to about 30% of the normal cardiac output that you have. So you're not giving people normal cardiac output. So it's important that CPR be understood for what it is, and that is a band-aid measure really to try and have some perfusion to the heart and to the brain until defibrillation occurs. And so if you have a shockable rhythm, a pulseless VT or a ventricular fibrillation, then defibrillation becomes the most important thing that you can do. Drugs such as vasopressors, adrenaline, or other antiarrhythmics such as amiodarone, which is the choice now rather than lignocaine, have not been shown to make any great difference. Adrenaline has been shown to increase return of spontaneous circulation. However, it doesn't make a great difference in terms of patient discharge to a useful life after an arrest. There is an emphasis on end-tidal CO2 with airway, and as always, be very, very careful to make sure that if you're doing an advanced airway on this patient, that it's in the right place. Because if you're putting an endotracheal tube in, you really need to make sure that you verify its position with end-tidal CO2 tracing. And that may be a little bit difficult given that in a cardiac arrest, they're not perfusing very well, so they may not be getting high end-tidal CO2s. End-tidal CO2 is also emphasised as a potential good way to work out when the patient does get a good output, because the end-tidal CO2 will jump. That's not to be confused with the potential jump that can occur in an end-tidal CO2 after you give bicarb, because bicarb goes to CO2 plus water. So if you're looking at trying to maintain an airway, it's probably not a good idea to try and intubate right at the beginning. If you do want to intubate, intubation shouldn't really delay your cardiac compressions at any time by more than about 20 seconds at the most. And so it's probably feasible to bag valve mask or laryngeal mask these days. So just to get a quick summary, it's 30:2. We give adrenaline after the second shock. So once we give the shock, and in a biphasic defibrillator we give 200 joules, we then give the adrenaline immediately and start CPR. It takes about 1.5 minutes for adrenaline to reach its peak levels in the blood. We assess for a shockable rhythm again. Now, if you go from a VT that's pulseless or a VF to an organised rhythm that may have an output, it's fine to check to see if there's an output at that time. But if it's a disorganised rhythm or it's a VT and there's no pulse, we know there's no pulse because they're not responsive, then it's fine to shock and start CPR immediately after the shock because there's cardiac stunning. So, defibrillatable rhythm, do some CPR until the pads are on, shock the patient, do CPR immediately after the shock. And so you should be charging the machine up whilst you're doing this 2 minutes of CPR, and then assess the rhythm. Is it a shockable rhythm again? Shock the patient right after that. Commence CPR immediately, and whilst you commence CPR after the second shock, you give the adrenaline. Okay? So my approach to resuscitation at this point is fairly straightforward. I don't intubate the patient at the beginning. I actually bag valve mask or laryngeal mask. I really do a hands-off in terms of any delay to CPR. So if we have a patient that comes there in arrest, in a full arrest, VF or pulseless VT, I will bag valve mask that patient, or I will put in a laryngeal mask in that patient, and I'll attach end-tidal CO2, so it gives me an idea of what we're doing. I won't do an endotracheal tube at that point. In fact, I won't do an endotracheal tube until the patient gets return of spontaneous circulation and has a blood pressure, and then I will intubate at that point. Because what I don't want to do is delay CPR, and what I don't want to do is have the tube in the wrong place and think that I'm oxygenating the patient when I'm not. I'm going to use 100% oxygen concentration, and I will bag, if I'm bag valve masking, either directly through a mask or through the laryngeal mask, I would do my 2 breaths after 30 compressions, each breath lasting for about a second. I will depress the bag to 500-600 mil tidal volume. I will give it as quickly as I can. Be very, very careful that you've got to coordinate the breathing in with the chest compressions, otherwise you don't get good ventilation. The other thing to be careful of is that if you do intubate your patient and you're bagging independently, that you don't hyperventilate your patient. In fact, most of the studies have shown that if you ventilate more than 10 times per minute, it's associated with 0 return of spontaneous circulation. And the reason for that is because you're hyperinflating them. You're increasing the thoracic cavity pressures, and so you're decreasing their cardiac return. And if you're decreasing cardiac return, you're decreasing cardiac output. So I will, the second a patient comes in, I'll take over the airway. I will say, start CPR right now, please. So start CPR. Let's get the defibrillator here, because that's going to make the biggest difference. Put the pads on. At the same time, I'll have the airway person, or if I'm the airway person, I'll bag valve mask that patient in unison. And what I'll ask the person doing the CPR to do is to get to 26, 27, 28, 29, 30, and then stop 2 breaths and then starts again. And when they're getting to 26, 27, 28, 29, telling us so that we can bag valve mask. As I said, attach it to end-tidal CO2 and 100% oxygen. You give CPR until the defibrillator is on, then you quickly assess the rhythm, defibrillatable rhythm. You defibrillate, biphasic defibrillators, which most people should have now, at 200 joules. There's a lot of biphasic waveforms. We're not quite sure about all of them. About 200 joules those be accepted. If you have a different biphasic defibrillator, then you should really have a look and see what the manufacturer of your defibrillator recommends. But about 200 joules is the norm. So we shock the adult patient and then start CPR immediately after the shock. And you can be recharging your defibrillator whilst the CPR is going on. One study done showed that with gloves you can in fact defibrillate with a biphasic defibrillator whilst you're doing CPR. I'm not sure that we're at that stage where we're going to do that yet. However, right after defibrillation, start the CPR, keep going. And so you're going for about 2 minutes in the cycle. So it's about 5 lots of 30 to 2. And so you go for about 2 minutes doing that CPR, and then you assess the rhythm. Is it a shockable rhythm on the monitor? If it is, deliver another shock to them, another 200 joule shock, and then start CPR immediately, okay, right after that shock. If nothing's happened post the shock, you can then give some adrenaline. So 2 minutes later, you assess again. Okay, if you need to give them another shock, give them another shock, then give them 5 milligrams per kilogram of amiodarone after that, and assess again. So we're looking at, a drug defibrillate type of formula. Important that in the adult patient, which we're talking about here, the main causes are going to be sort of cardiac type causes. This is very different from the pediatric patient, where the causes are predominantly respiratory. A very small group of the pediatric patients will have a cardiac cause for their collapse. So whilst you're doing all of this, and if the patient hasn't responded very quickly, you've got to start thinking of the causes, potential causes, and they are the 4 H's and the 4 T's. And so if you want to go through the 4 H's and the T's, hypoxia, so we give them oxygen. Hypovolemia is the other one, and it's a little bit controversial about whether IV fluids are helpful. I personally attach some IV fluids and give it to them, and that takes care of the potential hypovolemia, hypokalemia, hypothermia. Now, in most of these patients, we're going to be in a VF arrest. We're going to be aiming for hypothermia post the arrest anyway. And there is some very small work going on showing that potentially chilled fluid might actually help in converting them to a more manageable rhythm, although nothing's really out there validated enough for us to use. After the arrest, if we are going to cool these patients, we're going to cool them with 4 degrees normal saline solution. We're giving it to them at the rate of 30 ml per kilogram. So the 4 H's: hypoxia, hypovolemia, hypokalemia, hypothermia, and the 4 T's. So what are the T's? Is there tamponade, cardiac tamponade? Is there a tension pneumothorax? Are there some sort of toxins involved? And is there thrombosis, either of the pulmonary vasculature, which means a PE, or the coronary vascular, which is going to be a cardiac event? So as we're working on the patient, we've got to keep thinking about what are the potential causes. And if we're giving them oxygen and treating them with fluid, we've dealt with that. Listening to the chest, very important in case we think that they've got a collapsed lung of some sort and they've got a tension pneumothorax. And what's very important these days is, as we're continuing these arrests, the use of the ultrasound machine in the emergency department, being able to put the ultrasound machine on there and looking for a pericardial collection, looking for any cardiac activity, certainly in prolonged arrest. The final question, I suppose, is how long do we keep going for in an arrest? And there's some evidence that shows that if the end-tidal CO2 is continuously below about 10, then the chances of survival are very, very low or non-existent. We know that at about 25 to 30 minutes, when they've had no spontaneous output or return of any sort of circulation or organising rhythm, the chances of survival are very, very small. Now that's for VF and VT. How about the patient that comes in PEA or in asystole? In that particular patient, there's nothing to defibrillate. As much as you see it on telly where they've got an organised rhythm and they're getting shocked, it does nothing to help them. And so in the asystole or the pulseless electrical activity patient, we need to give adrenaline immediately because that has the greatest chance. And so start CPR, give adrenaline. Okay? Now, as part of all of this, we've got to start thinking about when do we get intravenous access and about giving drugs. And so intravenous access has to start occurring very, very early in the piece. And if you're starting to need to give adrenaline, for example, and we need to give adrenaline after the second shock, we need to have adrenaline sort of ready to go at about 2 minutes or so. So you've got about a minute or two to get intravenous access. And my belief in these patients is that the sooner we defibrillate, the better. But the sooner we might get some return of spontaneous circulation, it might assist us a little bit. I will go for an intraosseous line very, very quickly if I can't get a normal IV. And then you can give all your fluids and drugs and everything through the intraosseous line. The old idea of giving them through the endotracheal tube, well, we don't do that anymore. And that's my whole approach now of not intubating them at the beginning because it doesn't really matter. And it's been shown that giving the drugs through the endotracheal tube is not very effective anyway. So that's the new guidelines, 30 to 2. Don't interrupt CPR as much as possible. Minimise the time that you stop doing compression, so give your breaths quickly. Put end-tidal CO2 on bag valve masturbation or laryngeal mastum early as possible, but the CPR is important. Get the defibrillator on them, zap them as quickly as you can. Think about your causes. Only two other things to say perhaps, or one other thing to say, thrombolysis. Well, unless we think they've got a PE that's caused this, there's no real great evidence of thrombolysis, and there is some evidence coming out in terms of taking some of these patients to the cath lab. So stay tuned, there's a lot more stuff coming out. So new resuscitation guidelines, there's a summary of these on the website. Go and have a look at them, but I think it's really important to stay in touch with what the new developments are and the research behind it.